It's time for our Centric Health, Central Cardiology segment with Dr. Bridge Bombay. Joins us every Friday, man. I tell you, glad to have somebody like Dr. Bombay who kind of walk through what this coronavirus means, and particularly now after we saw that story in the Californian yesterday about, are we on the verge? There's a couple things happening. We now have patients being turned away from at least one hospital. Now, they say that's because of a staffing shortage. Now, it's well known that one of the reasons we have this staffing shortage is because this virus is making its way through some of our hospitals. And when you have people working in that dense environment and being exposed to where their viral loads are so high, I guess that is to be expected. But that does not bode well. I'll be asking Dr. Bombay about that as we go forward and the number of cases continue to climb. And here we are on day 3 of at least 200 or more cases. And today, 8 deaths. Not 1, not 2, but 8. I think that's a single day record for us. It seems clearly to me like we're going in the wrong direction, but who am I? I'm just a radio host. We're going to go to the source. Dr. Bridge Bombay. Dr. Bombay, welcome back to the show. How are you, sir?
Richard, I'm well. How are you?
I'm doing terrific. Dr. Bombay, I got to tell you, I don't think I've been this distressed over this virus. Just recently it hit me that, and you have said it, you've been very consistent from day one that we are in the early stage of this. And now when we see our hospitals filling up and struggling with staffing problems, what does that, number one, does that surprise you, sir? And number two, what does it tell you about where we are?
Nothing about this virus has been a surprise. It has been predictable to begin with and is adopting a predictable path. If we don't have behavioral adjustments at every single individual citizen level, you will face the other side of the virus, which is exponential growth and inability of the system to sustain the infections and downstream consequences. As we discussed, I guess, a few months ago, and you asked me, would we have a second wave? And I told you, if we did, we would have earned it. And it seems to me we're earning it. And that's hurtful at multiple levels because when you take away healthcare providers through community spread, you jeopardize, you minimize further the healthcare resources because that's something that cuts both ways in the wrong manner. And that's the struggle we have now. We are losing nurses, we're losing doctors, we're losing providers when we need them the most as the transmissibility in the community has increased. So I urge, with folded hands, I ask all the people in the community, please wear the mask, maintain social distancing. We know how to deal with the virus. We don't deal with it with bravado. We don't deal with personal invincibility. We deal with it with social responsibility.
Why is it, do you think, Dr. Bombay, that it's not, that message is not resonating with a lot of people, with large groups of people? Well, is it, we've talked about this before, but I'm still struggling with it. Is it part of the American psyche that we enjoy such freedoms that it's hard to get us to, even when our health is at risk, to accept some limitations on those freedoms?
I shared the struggles in the lack of assimilation of the message. Peter Marshall actually said it beautifully, that freedom isn't about what you can do with it, but it's an opportunity to do to what you can do for others. So we shouldn't be self-centered when we talk about freedom and liberty. We should talk about our accountability when we talk about freedom and liberty, because it's not a free pass So let me give you an example. I have a patient. His name is Dale Cheeseman. He's 98-year-old. He fought in the Second World War. He built ships. In 1968, there was a incident, a submarine, Russian submarine K-129, was submerged, drowned, and he was called upon to build the hydraulics of a ship to retrieve that submarine. And the pieces of submarine were retrieved, and nobody knows the details beyond that. At least I don't. He may. So I was talking to Dale. He's a nice gentleman with an easy smile, and never ever claimed the chivalry or the bravery or the sacrifices he put towards the country. Then I look at him, and if I talk to him and I sneeze at him without the mask on, you know what I call that? An act of vandalism. That's driving drunk. I have no idea how can you impart that wisdom to everybody that when you don't have the mask on, when you don't practice social distancing, you are hurting somebody who's susceptible, and that may be the person who gave you the liberty and freedom that you think you own, but was earned by others. And it's a simple matter of respect. Don't kill people who are susceptible. You are part of the solution. Please don't be part of the problem.
No, powerfully put. I will tell you, when you talk about so many nurses and doctors and providers that are not available, are they coming down? Is it are they COVID victims, or are some of them just leaving the business? Why are we facing these staffing shortages?
A lot of it is infection itself. So once a person is infected, we have to make sure that we take that person out. We don't want to disseminate the infection. A part of it is the fear factor. Part of it is that, you have heard in the news people want hazard pay. A part of it is the lack of the liability shield. In California, for instance, every COVID infection is a workman comp. So that's a burden on the employer as opposed to state picking up the tab. In my humble opinion, the employer did not create the COVID. Why should it be a workman comp on the part of the employer? So there are a lot of missing pieces that demand a logical solution, but it's not there. When a lot of people who see the COVID, so there are two segments of society. One who think they're invincible, they have never seen or come across a patient with COVID. And then there's nurses who work in the ICUs and ERs. They see the sickness. They see the severity of the sickness. So it does inflict a certain amount of fear in them. Yes, infection. Yes, fear. Yes, lack of compliance with the society in general that keeps on giving us the workload and taking away the people who need to take care of the workload.
You've talked a lot before talking to Dr. Bridge Bombay. If you have a question for him, give us a call, 842-537-6842-KERN. If you have COVID or if you have a loved one have COVID, we have an expert here who will try to answer your questions. Dr. Bombay, when you've talked a lot about viral load and how important that factor is. In other words, how long a person is exposed to the virus will go a long way in determining if, in fact, they contract it. Now, when you have so many people working in a hospital session and so many where you have patients there, even with all the protective gear, what are the chances that is it just inevitable that a certain number of people are going to come down with the virus themselves?
If the PPEs are adopted by the book, then the probability of infection being acquired by the person who's protected should be close to nil. It's never zero, but should be close to nil. That's what they found in China in the second stage in Wuhan, that about 20-some thousand healthcare workers who were properly clad in PPE never got infection. But the problem is you don't know if you're dealing with COVID or not, because everybody, when we have community transmissibility at a community level, when the positivity rate goes so much, the people I may think are COVID-free, and thus I go and treat them like they don't have COVID, is a gamble I take every time. So the fact is we don't have enough PPEs to burn through every encounter, considering and respecting it as PPE, as a COVID encounter. And therein lies a vulnerability that, unbeknownst to us, when a person has COVID, we are not prepared to deny the virus to jump to us. We allow it to jump to us.
Oh, man, good Lord. What, talk to me a little bit about what people don't see when how something, anecdotally I've heard that when a lot of people will survive the virus, but yet have some, it will affect them medically in some way, some long-term effects. We don't talk about that a lot. I think particularly maybe younger people feel like, well, I'm young, I can get it, and then 14 days or whatever, and I'll be fine. What are some of the things we see that people have to deal with even when they're virus-free?
So this virus, we're learning a lot about. And it's not just a cold or a flu virus. It affects the entire system. It affects the brain, blood vessels, lungs, even cognitive functions. What we have seen is that a lot of people, we genetically, in layman language, call them long haulers. So they develop myalgic encephalitis, and they have lingering chronic fatigue syndrome. The mental alertness is dimmed, the physical component is continuous, and then there is a concern, not a concern, there's evidence that the lungs can be damaged. On a long-term basis, I can't say the duration of that because the disease is only 6 months old, but the lungs fail to recover as one would expect in a lot of cases. So this isn't a one in and out disease. And then the other thing we have mentioned, talked frequently in the past, is about the immunity. The concept of immunity also stands on a slippery slope because we just extrapolate infection in general and say, yes, infection will lend us immunity. But we don't have the evidence of that it'll be durable immunity, it'll be effective immunity, it'll protect us from second infection. None of those issues have been settled. If those issues are not settled, the issue of vaccine is not settled either. So the first line of defense is to take precautions. Everything else follows afterwards.
Well, Dr. Bombay, if we don't know, if number one, people who get the virus are going to be immune, or if they are, how long they may be immune, and maybe it's just a short period and the antibodies disappear at some point. How does that affect the whole concept of herd immunity? Because isn't herd immunity built on the idea that if enough people get it, everybody's get it, and then how can you have a herd immunity if there's not a sufficient buildup of antibodies after you've had it?
It's a very troubling and important question. The herd immunity can be achieved if there's no immunity. Just a herd then. So there are two components of immunity. One is antibodies. What we have seen is that when people have infection, depending upon the severity of infection, the antibody response is variable. And typically speaking, in people who are asymptomatic or have had mild disease, the antibodies tend to dissipate in 90 days. But there is hormonal antibodies, and then there is cellular antibody protection, which is through cells called B cells and T cells. And these cells called lymphocytes in the body remember what happened. And if there's a recurrence of infection, then they can start releasing antibodies and react to that. The concern many people share is that what if the immunity is partial? What that means is if a person has partial immunity, he may get the infection again, may spread the virus, but may not get hit himself because he has partial immunity. But that doesn't mean that he won't be spreading the virus. So there are too many questions, and some of them are disturbing because we haven't had the time to answer those. But we're just trying to extrapolate. The reason I have been an advocate of herd immunity is that there is no alternative. So let's say the immunity is partial and not long-lasting. We still have to get the infection because that's how we are going to, as a society, as a country, as a world, going to minimize the lethality and the virulence of the infection by having a widespread of the population partial immunity to it. Now, if the virus lends us partial immunity and the vaccine isn't going to be a super treatment that's going to somehow stimulate immunity over and above a viral infection will do. There are a lot of unsettled questions. What I'm most sanguine about is that if we practice the safety measures, we will allow pharmaceuticals to catch up. And the pharmaceuticals are catching up big time in the treatment of COVID, both in the mild, moderate, throughout the whole spectrum, mild, moderate, and severe. Using the steroids, using anti-inflammatory agents, using intubations sparingly, using a lot of techniques, we are able to lower the mortality. And another thing which I find very encouraging is that all my patients who are in their 60s, 70s, 80s, 90s are very tuned to the fact that they have to stay away from infection. Part of the reason the mortality is going to go down is the absorption of the message in the people who are susceptible.
Right. Well, that's good news. Oh, okay. It's 2:24 here. We're about out of time. One last question for you, Doc. I mean, there's been some data about how the people of color and people on the lower end economic ladder at the lower end of that have such higher, they're getting hit hardest. But yet these are the people who JR and I were talking about earlier. They have to go to work. Maybe they don't have the option of living at home. You have multi-generational households. How can we possibly deal with that if you've got multiple families in a household, multiple exposure levels? That just seems like an almost impossible task.
It is an impossible task because there are 3 C's we have to avoid: crowds, close contacts, and closed spaces. When you have multi-generational house, you have all 3 C's in there. You're crowded, you are in closed spaces, and you're in close contact. So that's where the virus is spreading. The 2 sources of the virus spread have been the community intergenerational homes, and bars. So we take the bars out of the equation. That's where the major threat is. So there was an interesting disparity in New York data that in all the hospitalizations, only 17% of the people who were hospitalized actually worked, and only 3% took the subway. So the interesting thing isn't the interesting thing is that the work didn't seem to spread the infection.
They're getting it home. They're getting it with their family and friends. Is that what you're saying?
That's right. And so that lends some intellectual provocation that is it better to open the schools and release the people from closed infections in intergenerational crowded homes and give them a little breather?
God, I didn't even think of that. That's a whole nother twist on the whole school question, which we haven't even hit on. We've run out of time, too. Dr. Bombay, thank you so much for coming on. I appreciate it, sir. Have a safe weekend. We'll continue the discussion next week.
Thank you, Richard. You too.
Okay. Thank you, sir. Appreciate it. All right.